What's up, Ninja Nerds? In this video today, we're going to be talking about pericardial diseases. We have a lot to talk about, so let's get right into it. When we talk about pericardial diseases, there's something called acute pericarditis, constrictive pericarditis. We'll then talk about something called pericardial effusions. And last but not least, we'll talk about the most dangerous of these called cardiac tamponade. Let's first focus on the causes of these pericardial diseases. So when we talk about the causes of acute and constrictive pericarditis, they happen to be the same. You want to know why? Acute pericarditis usually leads to constrictive pericarditis. So acute pericarditis is an acute inflammation of the pericardium. Constrictive pericarditis is usually chronic pericarditis or recurrent bouts of acute pericarditis. So if we know the causes for acute, we know the causes for constrictive. What are those causes? The first one is infectious. So infectious tends to be one of the big causes, and we actually kind of technically consider it to be under the umbrella of idiopathic. So idiopathic is technically the most common cause of pericarditis. However, we suspect in those cases that we don't really know, it's likely infectious, viral particularly. So viruses that you definitely want to remember and do not forget are going to be the Coxsackie B virus, as well as another one, a newer one, SARS-CoV-2 virus that causes COVID-19. The second one is bacterial. So bacterial, there's different types of bacteria. One of the big ones that you don't want to forget is tuberculosis. And this happens to be one that very, very consistently can lead to chronic pericarditis and cause constrictive pericarditis. All right, so we have infectious etiologies. The next one is uremia. So uremia is in patients who have end-stage renal disease. They have chronic kidney disease, likely they're on hemodialysis at this point. And the urea levels in the blood are so high that they tend to start causing inflammation of the pericardium. So this is called uremia. The next one is autoimmune etiologies. This is usually some type of autoantibodies that are being produced in someone's underlying disease process. Usually they have an underlying autoimmune disease, particularly SLE, so systemic lupus erythematosus, or RA, rheumatoid arthritis. And these patients, they produce autoantibodies that attack different tissues, commonly the joints, right? So they'll obviously have joint pain, arthralgias, but on top of that, these autoantibodies tend to attack other tissues, such as the pericardium, and can lead to pericarditis. The next one is the post-cardiac injury syndromes. And there's a couple different components to this under that umbrella term. What are those? The first one you want to think about is those kinds of conditions that can actually cause pericarditis after someone's had a myocardial infarction, so post-MI. Now, if they've developed pericarditis 1 to 3 days after their MI, it's likely what's called PIP, peri-infarction pericarditis. If it's likely 3 days to 14 days after their MI, it's likely something called Dressler syndrome. And usually the difference between this is Dressler syndrome is due to autoantibodies. Peri-infarction pericarditis is just the local inflammation from the MI. The second type of term that we want to think about that is under this umbrella of post-cardiac injury syndrome is something called post-pericardiotomy. So this is usually when someone has actually gone mucking around near the area of the heart, particularly during open heart procedures, all right? So this could be an iatrogenic process. If you're going in and opening up the pericardium, doing a cabbage, or doing some type of mitral valve repair, anything that involves opening up the heart, therefore hitting and tearing open the pericardium, that can lead to pericarditis. But this might not be iatrogenic due to the actual practitioners. It could be inadvertently traumatic from someone having a penetrating trauma like a knife going right into the heart. So these are the things that I want you to think about for these post-cardiac injury syndromes. Last and but not least, that could be triggers or causes of someone having pericarditis could be due to neoplasias. And there's particular neoplasias that you have to remember that can metastasize and spread to the pericardium. This includes lung cancer, lymphoma, renal cell carcinoma, and breast cancer. You know what else is really interesting? Generally, these patients have these types of cancers that can cause pericarditis. They also usually have to get some type of treatment for that. Guess what it is? Radiation therapy. That radiation therapy itself for these cancers, particularly lung and lymphoid and breast, also are near the vicinity of the heart. And so sometimes it can inadvertently hit the pericardium as well. These are the particular causes for acute and constrictive pericarditis. One quick thing though is for constrictive pericarditis, there tends to be 3 particular diseases that are most commonly going to cause this constrictive pericarditis out of these things that we talked about for acute. And those include tuberculosis, some type of neoplasia, or radiation therapy. Those are one of the 3 most common causes of someone having chronic pericarditis that leads to constrictive pericarditis. Let's now talk about pericardial effusions and tamponade causes. All right, so let's talk about the causes of pericardial effusions and cardiac tamponade. So pericardial effusions and cardiac tamponade, by definition, pericardial effusion is fluid that's accumulating within the pericardial cavity, right? But it's not causing what's called tamponade physiology. I'll explain what that means. So what could be reasons why we would develop fluid or pus or blood or any kind of, technically, any fluid that can accumulate in the pericardial cavity? What could be causes for that? We've already talked about all the causes just above. So don't forget, all of the things that cause acute and constrictive pericarditis can also cause pericardial effusions. Infectious diseases, autoimmune diseases, uremia, post-infarction myocarditis, as well as particularly neoplasias and radiation therapy. So don't forget those. The other thing that you want to remember that can cause pericardial effusions that are not due to these acute and constrictive pericarditis causes is it could be due to a nasty purulent infection, lots of loculations, lots of nasty pus and white cell material that are accumulating in this pericardial cavity. This is usually due to this nasty bacterial infections. Tuberculosis can be one of those, but another particular ones that you want to be thinking about is Staphylococcus aureus or Streptococcus pneumonia. And really the best way to remember these as causing purulent effusions is anytime you open up the thoracic cavity. Anytime you're doing anything near the lungs, anytime you're opening up the heart in any way, shape, or form, you invite bacteria to invade into those tissues. And so it can invade right into the pericardial cavity and cause these pericardial effusions. So again, Staphylococcus aureus, Streptococcus pneumonia, and TB. What are the risk factors? Well, for these Staphylococcus aureus and Streptococcus pneumonia, it's technically any thoracic surgery where these bacteria can easily move into the pericardial cavity. For the patients with tuberculosis, it's usually they are immunosuppressed. And so this increases the risk of having TB. In these cases, it would be patients with HIV, AIDS. They're on some immunosuppressive therapy. They're on chemo. They have an organ transplant. Something of that nature increases their risk of getting TB. Okay? So these are the purulent effusions. The next one, which is another thing that can cause fluid to accumulate besides the acute and constrictive pericarditis, besides the purulent effusions, is blood. So a hemopericardium. So hemopericardiums are where blood accumulates within the pericardial cavity. And this could be due to nasty things such as an aortic dissection. So sometimes if your aorta actually dissects the proximal point, it can empty right into the pericardial cavity. Or if your left ventricular wall explodes and blood just kind of empties right into the pericardial cavity here, such as in a wall rupture after your post-MI patients. Or they have a coagulopathy, so they're on anticoagulants, they've gotten TPA, and they have some underlying like uremia, and can convert that into a hemorrhagic pericardium. And the last one is anytime you perform any kind of penetrating trauma that opens up an opportunity for blood to empty into the pericardial cavity. So these are the things that can lead to hemopericardiums, which is a type of fluid in the pericardial cavity, which is called a pericardial effusion. Now here's the big question. What is the difference between someone having a pericardial effusion and cardiac tamponade? Because they're both having fluid material within the pericardial cavity. The point at which we define cardiac tamponade is it could be any of the things that we just mentioned. They could have a hemopericardium due to the blood. They can have a purulent effusion due to these bacteria. Or they could have some type of malignant effusion, whether that be from neoplasia, whether that be from radiation, whether that be due to infectious lesions, autoimmune diseases, any of these causes up above. What's the difference though is that this actual effusion starts leading to something called tamponade physiology. What the heck does that mean? So imagine here in pink, this is the stretch limit of the pericardium. So whenever you have this fluid that's accumulating within the pericardial cavity, it's going to cause it to stretch. There is a limit to how much this pericardial cavity can actually stretch. So how do we determine that? Here's this pink line here which determines the stretch limit of the pericardium. Now, let's say that you have something like a hemopericardium. Hemopericardiums usually accumulate very rapidly. When they accumulate rapidly, imagine blood pouring into this pericardial cavity. And when it pours into the pericardial cavity, what you want is you want the pericardium to stretch to accommodate that blood. When it occurs so quickly, the pericardium doesn't have time to stretch and accommodate that volume. And so it goes above the stretch limit of the pericardium. Once you're beyond the stretch limit of the pericardium, your pericardial pressures start increasing. And instead of them actually allowing for this pericardium to stretch, they start compressing and squeezing on the heart. And that reduces filling into the heart. So that's one particular reason. The second reason that someone can develop tamponade is that it's a slow effusion. So you have fluid that's accumulating, and it's accumulating slowly. And again, as it accumulates slowly, the pericardium has time to stretch, accommodate, stretch, accommodate, stretch, accommodate. But once it gets to the point where it can no longer stretch anymore because the amount of fluid that you have in the pericardium exceeds its stretch capacity, we pass over into tamponade physiology. Pericardial pressures rise, they compress the heart and reduce the filling of the heart. That explains the basic causes and the pathophysiology behind a lot of these pericardial diseases. Now, my friends, let's talk about the clinical features and physical exam findings. All right, so let's talk about the clinical features and physical exam findings in these patients with pericardial diseases. The first one we'll talk about is acute pericarditis. So in acute pericarditis, it's inflammation of the pericardium is their pathophysiology, right? So we talked about all the causes. There's infectious, there's autoimmune, there's neoplasia, there's radiation, there's post-pericardiotomy syndromes or post-cardiac injury syndromes. And then again, there's likely some type of cause there, like uremia as well. Either way, there's inflammation of the pericardium. The two particular features that comes from an inflamed pericardium that you have to remember off the physical exam is a friction rub and a very classic type of chest pain. Let's talk about those. So the first thing is they have a chest pain. Their chest pain is very, very specific, and we can categorize their chest pain in a couple different ways. The first one is this defined as pleuritic. What the heck does that mean? That means that the pain hurts. It's worse whenever they take a breath in. Whenever you inhale, your lungs are supposed to expand, and they expand in all directions towards the chest wall, and whenever they expand, they have to expand this way. And so they expand and sometimes compress onto that poor inflamed heart and pinch it, squeeze it a little bit, and that precipitates a worsening of their actual chest pain. The other thing is we describe that pain very specifically as sharp and stabbing. It's usually retrosternal or substernal, but the classic feature for this one, again, sharp stabbing that radiates to the trapezius ridge is a classic finding in these patients. So pleuritic hurts with inspiration, sharp stabbing radiates to the trapezius ridge, okay? The other thing is it's positional. This is not the case in anginal chest pain. So what happens in these patients is they have a reduction in the intensity of the chest pain when they're actually sitting up, but more particularly when they're leaning forward. When you lean forward a little bit, you take some pressure off of the actual chest wall, particularly right underneath that is the heart. The second thing is when you're leaning forward, your diaphragm actually drops down a little bit. And when it drops down a little bit, there's less compression on the apex of the heart, especially the pericardial area. And that less compression of the area leads to less pain. So less intensity of chest pain when you're sitting up, but more particularly when you're leaning forward. What precipitates an intensity or provocation of the pain is usually when they're lying down supine or they're laying flat. When you lay flat, something very interesting happens. When you lay flat, all your abdominal organs start pushing up against the diaphragm. When it pushes up against the diaphragm will mash up against the bottom part of the lungs and against the bottom part of the heart near the pericardium. When it compresses that pericardial area, it precipitates a worsening of pain. And so again, that is why the intensity of chest pain is worse when you're lying down supine or flat. It's because when you lay down flat, abdominal pressure, it pushes the diaphragm upwards, what compresses on the actual apex pericardial area of the heart, precipitating a worsening of pain. So those are the big key features for that inflamed pericardium. What's the other feature for the inflamed pericardium? Let's come down and take a look at what happens here with the friction rub. All right, so what happens with the friction rub? So again, with that inflamed and irritated pericardium, right, what happens is it rubs up against the particular chambers of the heart during the cardiac cycle. And what happens is whenever the atria actually undergo this contraction, it can kind of rub up against that very irritated pericardium and cause a friction rub. And so sometimes you get this like scratchy type of heart sound that is very particularly a triphasic sound. So you hear it during the 3 phases of the cardiac cycle. When the atria are contracting during systole, when the ventricles are contracting during their systolic process, and whenever the ventricles are relaxing during the ventricular diastole. In those 3 periods, you can hear this scratchy type of heart sound and very, very particularly specific for a patient with pericarditis. Let's take a listen to that real quick, and then let's talk about constrictive pericarditis. All right, so let's now talk about constrictive pericarditis. What happens, what are the clinical features and physical exam findings here? So big thing, when you have constrictive pericarditis, the problem with this disease, the pathophysiology, is that rigid and very stiff pericardium. Remember I told you with recurrent bouts of acute pericarditis or with chronic pericarditis greater than 3 months, these patients get a fibrous, very elastic type of shell that occurs around their pericardium, within their pericardium, and because it's super fibrous and stiff, it doesn't want to allow for the ventricles to expand into the pericardial cavity. So it's very rigid, very stiff pericardium. Because of that, every time blood tries to come down into the ventricles during the ventricular diastole, the actual pericardium doesn't allow for the ventricles to expand. And so what happens is this reduces the ventricular filling process. If you reduce blood flow into the heart during the diastolic period, you reduce the amount of in-diastolic volume, or the preload, into the heart. If you reduce preload into the heart, you can potentially lead to these particular symptoms called heart failure symptoms. We'll talk about that. There's also another important sign here called a Kussmaul sign we'll talk about, and a pericardial knock. These are the three classic features of a patient with constrictive pericarditis, and it is due to their rigid and stiff pericardium reducing the ventricular filling process. So they have heart failure symptoms. There's two types of heart failure: right heart failure, left heart failure. In these patients with constrictive pericarditis, it tends to compress and be more rigid and allow less expansion of the right side of the heart in comparison to the left side of the heart. So they have more right heart failure symptoms than they do left heart failure symptoms. So what are the classic findings of right heart failure? Well, imagine this constrictive type of pericardium, this rigid pericardium, doesn't allow for the right ventricle to expand. So it doesn't get enough blood that comes into the right ventricle during diastole. That means that the blood channels stay plump within the superior vena cava and inferior vena cava. If the blood channels are filled up plump within the superior vena cava, all the way up to this big vessel here in your neck called the jugular vein, that'll get plump. And so it'll cause jugular venous distension due to high jugular venous pressures. If the inferior vena cava, the blood channels in there stay high because we can't get blood into the right side of the heart, so it just dumps backwards or upwards. If you go down the inferior vena cava, you have your liver here. It'll cause the liver to get bigger. It can cause ascites, fluid within the peritoneal cavity, or it can go all the way down to the lower extremities and cause pedal edema, lower extremity edema. So these are the classic features. Now, left heart failure is less common in these patients with constrictive pericarditis, okay? But if they did have these features, again, you're compressing, you're having that rigid pericardium, which is reducing the ability for the ventricles to expand during diastole. Less blood is coming into the left ventricle during diastole. That means that the blood channels get filled up within the pulmonary circulation. If blood backflows into the pulmonary circulation, this can lead to pulmonary edema. Classically, this will present with paroxysmal nocturnal dyspnea when they have laying down at night, going to bed. They have shortness of breath. When they're laying flat, orthopnea, they have shortness of breath. Or they have dyspnea just at an exertion or on rest. The other thing is, because you're having less volume coming into the heart during diastole, that lowers what's called their in-diastolic volume, that lowers their preload, that lowers their stroke volume, and that lowers their cardiac output. If less blood is getting pumped into the aorta and out into the actual peripheral tissues, what will that present with? They may have what's called a reflexive tachycardia. Whenever you have a drop in your cardiac output, it maybe drops your blood pressure a little bit. What happens is your sympathetic nervous system tries to compensate for that and increase your heart rate so that you can increase cardiac output. So that's one thing. And the other thing is, if you have poor perfusion to particular tissues, their extremities will be cool, they'll be cold, they'll be pale, they'll be clammy type of appearance, and they may have decreased cap refill, a lot of signs of just not well perfused extremities. And so these can be potential signs that you see in left heart failure. But again, right is more common than left in these patients. Okay, so we get the heart failure symptoms. Let's come down and talk about two other signs that we see in these patients via the Kussmaul and the pericardial knock. All right, so Kussmaul sign. This is a very important sign within constrictive pericarditis. You can see it in cardiac tamponade, not as common, but you definitely want to remember this. Out of all of these pericardial diseases, do not forget Kussmaul for constrictive pericarditis. Now, what happens in this? Well, we know the problem with constrictive pericarditis is they have the rigid pericardium does not allow the ventricles to particularly open up and expand. And again, more particularly on the right side. So what happens is when you take a breath in, you take an inspiration, your intrathoracic pressure should drop. When your intrathoracic pressure drops, it creates this sucking effect within the right side of the heart, where it yanks blood into the right atrium and into the right ventricle. What should happen is you try to cause the blood columns within your jugular vein and with an inferior vena cava to just rapidly drop and go yank down and go up into the heart, okay? That's what normally should happen. So your jugular venous pressure should drop during inspiration in normal individuals. But in these patients with constrictive pericarditis, the rigid pericardium is compressing and reducing the actual filling process in the right ventricle. So whenever this tricuspid valve opens, blood should flow down quickly into the right ventricle, but then again, the ventricle should expand, but it can't expand against this rigid pericardium. So blood flow stops. That naturally causes this jugular vein system to be distended. Normally, if you have jugular venous distension in any other kind of patient, except for constrictive pericarditis, it should drop during inspiration. But If it stays elevated or stays distended during the inspiratory process, this is called a Kussmaul sign, and it's very specific for a condition called constrictive pericarditis. There is another differential that I do not want you to forget. So sometimes you can see this in a condition called restrictive cardiomyopathy. But we'll talk about how we differentiate those. And we've already talked about that in our cardiomyopathy video. Okay, so Kussmaul sign, paradoxical increase or sustaining JVP during inspiration. The next one is the pericardial knock. This is another very specific finding. So what happens is because of this rigid and very, very stiff pericardium, again, during the actual process of when your early diastole, those valves open and blood floods in very quickly, but then it stops suddenly because, again, the rigid pericardium doesn't allow for the ventricles to expand to accommodate more blood. So what happens is when blood flows rapidly into the ventricles and suddenly stops, it produces this thing called a pericardial knock. And this is, again, an early to about mid diastolic heart sound that you may hear in these patients with constrictive pericarditis. All right, so let's talk about the clinical features of cardiac tamponade. Now, you might be wondering, well, what about pericardial effusion? We didn't talk about that. Oftentimes, it's not even really worth remembering a lot of the features of pericardial effusion because they're very nonspecific. And a lot of the times, they're actually symptoms of pericarditis. So generally, whenever you think about pericardial effusion, some of the things that may tip your balance in thinking about that is, again, a patient who has features of pericarditis with maybe some decreased or distant heart sounds that you can hear. And sometimes they may have a very nonspecific sign called an Ewart sign, but those aren't going to be super helpful in the diagnosis of a patient with pericardial effusion. So we'll think about that in the diagnostic steps. But let's talk about the clinical features and physical exam findings that are very pertinent for cardiac tamponade. So first thing is, what is the pathophysiology behind this? So there's lots and lots and lots of fluid, or there's rapidly accumulating fluid that occurs within the pericardial cavity. And what that starts doing is, the big difference here between a pericardial effusion is it starts compressing the heart, strangulating the heart, and reducing blood that enters into the heart during the diastolic period. So it's really strangulating, squeezing the heart, and reducing the diastolic filling process. If you reduce the ventricular filling process excessively, so severely, you can actually cause very, very particular findings that we're going to talk about. So what are the classic features that I want you guys to remember for cardiac tamponade? This includes things like Beck's triad, we'll talk about that, pulsus paradoxus, and obstructive shock. So these are the things that I really want you guys to remember for a patient with cardiac tamponade. So let's talk about what's Beck's triad. We know Beck's triad is due to this, again, whole process of compression of the chambers of the heart, reducing the ventricular filling process. What happens with that? Well, the first thing is again, if you compress the heart and you reduce the filling process into the right side of the heart, can you get blood into the right heart? No. And so it backs up into the superior vena cava and into the inferior vena cava. If it obviously backed up into the inferior vena cava, you'd have hepatomegaly, ascites, and pedal edema. If it backed up into the superior vena cava, it would back up into the jugular vein and cause jugular venous distension. This is due to the decreased right heart filling. The other thing is you have all this fluid that's accumulating in the pericardial cavity. Whenever you have your heart sounds, the S1 and the S2 heart sounds, S1 is the closure of the tricuspid and the mitral, and S2 is the closure of the aortic and the pulmonary semilunar valve. Those generally get transmitted to the chest wall, which we hear with our stethoscope. If there's all this fluid that's affecting the conduction of those heart sounds, it'll sound diminished, it'll sound distant, it'll sound like decreased heart sounds or muffled. And this could be a sign of a lot of fluid that's actually, again, the space between the heart and the chest wall. The third thing for Beck's triad is hypotension. And again, because all of this fluid is compressing down into the ventricles, and when it's compressing down into the ventricles, it's reducing the ventricular filling process. If you get less end-diastolic volume into the left ventricle, that results in a drop in their preload. If you drop their preload, you drop their stroke volume, that drops their cardiac output, and that can drop their blood pressure. And so you can get hypotension as another potential sign of these patients who have cardiac tamponade. And again, within this thing of Beck's triad. So Beck's triad is JVD, distant heart sounds, and hypotension. Okay, that's one classic feature. The second classic feature is what's called pulsus paradoxus. Sometimes it's just referred to as pulsus. So what happens is, again, you're having this large amount of fluid or rapidly accumulating fluid that's compressing the heart, particularly the ventricles, right? When you're compressing the ventricles, particularly the one that gets more compressed than the other is the right side. The right side has a thinner myocardium, so it's easier to compress that side than the left side. What happens is if you compress the right side of the heart, again, you reduce the filling process into the ventricles. So generally the whole part is you can have some blood come in and the ventricles will accommodate that, but if it has any more blood that's trying to come in, it won't be able to expand because it's being abutted by that pericardium. So what happens is very weird is normally whenever you take a breath in, you take a deep breath in, it drops your intrathoracic pressure, pulls blood into the heart, right? When you pull blood into the heart, and particularly into the right ventricle, you get some volume of blood that comes into the right ventricle, and it just, I'm talking very minorly, shifts the septum to the left, which reduces the blood flow into the left side of the heart and reduces the outflow. Very minorly, to the point where it doesn't really drop the systolic blood pressure from the left side more than 10 millimeters of mercury. In a patient who has cardiac tamponade, this filling process is super impaired. So blood will rush into the right ventricle during diastole, and it can't expand out this way, so guess where it has to expand? The septum. And it shifts the septum super hard to the left side, obstructing the left side of the heart. You can't get as much blood into the left heart, and you can't get as much blood out of the left heart during inspiration. And that drops your pressure precipitously, more than 10 millimeters of mercury during inspiration, which is paradoxical. And so we see a paradoxical drop in systolic blood pressure greater than 10 millimeters of mercury during inspiration. If we looked at an arterial waveform, and you were actually having the pressure here on the y-axis and time in the x-axis, you would see that during expiration, here's your pressures, right? Maybe 120 over 80 millimeters of mercury in a perfect world. But then if we go here during the inspiratory phase, whoop, we see a significant precipitous drop in that systolic blood pressure. Maybe it went from 120 to 100 during the inspiration. Then they take another breath out, and then the pressure goes back up to 120. So you can see that whenever the blood pressure systolically drops more than 10 millimeters during inspiration, that's a classic finding of pulsus paradoxus, which is seen in cardiac tamponade. Let's talk about the last finding here, which is obstructive shock. All right, so obstructive shock, this is the last particular finding for cardiac tamponade, one of the scariest ones. So in cardiac tamponade, we already know that they're going to be hypotensive, right? They're hypotensive because of a significant drop in venous return. They're not getting proper ventricular filling. So they're getting a drop in their end diastolic volume, drop in their preload, drop in their stroke volume, drop in their cardiac output. Now, when someone's cardiac output drops, what happens is you try to reflexively compensate for that. And so you'll have a patient who's hypotensive, but they're going to try to compensate by increasing the heart rate. Because if you increase the heart rate, you increase your cardiac output effectively. You're trying to. The other thing that happens is whenever your cardiac output drops, not only do you try to increase your heart rate to increase your cardiac output, you actually try to increase your blood pressure by squeezing down on their vessels. And when you try to squeeze down on the arteries, it increases their systemic vascular resistance. If you increase their systemic vascular resistance, that should try to increase their blood pressure. So one of the classic signs of obstructive shock is a patient with hypotension, reflexive tachycardia, and a very strong vasomotor tone, where they may have reduced perfusion to their extremities. The other thing that is really important is because they have all of this fluid that's compressing on the right side of the heart more than the left side of the heart, they're getting very little venous return. And because they're collapsing this right side of the heart, the pressure that's occurring in this right side of the heart is much higher than usual. It's very high. And it's causing like the superior vena cava to become distended, the inferior vena cava to become distended, and that right side of the heart is just really high pressure. And so this is indicative of having little venous return in these cases. And so sometimes if you put in what's called a Swan's-Ganz catheter or a right heart cath and you measure the right atrial pressure and the right ventricular pressure, it'll be very high because this amount of fluid in the pericardium is just compressing on the right side of the heart, really jacking up their pressures. The other thing is if you check their left atrial pressure, so you actually went and checked their left atrial pressure, their left atrial pressure will be really high. So how do we actually check left atrial pressure? We actually float that Swan's-Ganz catheter all the way down into the pulmonary vessels, and we measure something called a pulmonary capillary wedge pressure. So this tells us if the left atrial pressure is high. If the left atrial pressure is high, that means that, again, I have something that's compressing the left atrium as well, causing the blood to backflow into the pulmonary circulation. And so in patients with obstructive shock, not only are they hypotensive, tachycardic, high vasomotor tone, high central venous pressures or high right atrial pressures, along with high right ventricular pressures, but they also have high pulmonary capillary wedge pressures because their left atrium is being collapsed from the fluid, and that's causing high left atrial pressures, fluid to back up into the pulmonary circulation, and causing the pulmonary capillary wedge pressure to be greater than or equal to 18 millimeters of mercury, which tells me this is a cardiogenic source of pulmonary edema or high pressures within the lungs. Okay, so this is the classic findings of someone with obstructive shock, and again, what we see in a patient with cardiac tamponade. Let's now talk about the diagnostics behind all of these pericardial diseases. All right, engineers, let's move on to the diagnostics. So for acute pericarditis, how do we go about diagnosing these patients? Well, you have to meet the particular criteria for diagnosis. We've already hit really hard on the two particular clinical features and physical exam findings, right? That was the friction rub and the type of chest pain. That is actually those are two of the four particular criteria that we need to diagnose acute pericarditis. So we have the classic type of chest pain. That's the pleuritic type of chest pain, hurts during breathing. It's substernal, it's sharp, it's stabbing, it radiates to the trapezius. It's positional, worse when you're actually lying flat, and again, better whenever you're leaning forward. We already talked about that. We also have that friction rub, that triphasic scratchy type of heart sound. The other two particular findings that we need is someone to have these typical type of ECG changes that we'll discuss, and the last criteria is they have to have a new or worsening pericardial effusion. Now, what are the particular types of ECG changes that we're looking for in the diagnosis of acute pericarditis? The big thing here is they have diffuse ST segment elevations that are concave in configuration, which is very important. So diffuse ST segment elevation, you see this in multiple leads, precordial and limb leads. And when we see this ST segment elevation that's either greater than or equal to 1 millimeter in multiple leads, we also look here, and when you look at the actual configuration of this ST segment elevation, it looks like a smiley face. That's a good thing. You want to see that type of configuration because it's more suggestive of something such as acute pericarditis in comparison to something like an MI. The other thing that you really want to see is not just diffuse ST segment elevation without reciprocal changes. You want to see something called PR segment depression. This is also seen in kind of a inflammation type of pericarditis situation, where when you look at the PR segment is depressed below the isoelectric line. And so this PR segment depression, usually more commonly presenting within like the limb leads, but you can see them in really any lead, is another particular finding that is very, very specific for pericarditis. So diffuse ST elevation in the concave configuration without reciprocal changes, and PR segment depression is highly specific for acute pericarditis. The last thing is that after the ST segment elevation occurs, sometimes they may keep the PR segment depression and then eventually have something called diffuse T-wave inversion. So you may see the ST segment elevation convert eventually into diffuse T-wave inversion. And so that's generally kind of the stage process here. As you see ST segment elevation, PR segment depression, and then the diffuse ST elevation converts into diffuse T-wave inversion. Those are the EKG changes. For the effusion, how do we find a new or worsening type of pericardial effusion? You get an echo. You got to look at the actual heart. You want to look at the pericardial cavity and look for an effusion. You can do things like a CT MRI, but that's not necessary. Getting an echo, a formal echocardiogram, would tell you if there's a pericardial effusion, the size of it, if it's new, if you compare it to previous echoes, or if it's getting worse and rapidly expanding. That is how we diagnose acute pericarditis. Pretty simple, right? All right, for constrictive pericarditis, there's a bunch of different things that we want to look at. One of the things with constrictive pericarditis is we can use a bunch of different types of tests and physical exam findings in sequence to make sense of this condition. Their problem is reduced ventricular filling due to the rigid pericardium. Right? That's their issue. That rigid pericardium is reducing the ventricular filling process. We can actually pick up some of those actual signs on multiple different types of physical exam, laboratory, and imaging studies. So, if we actually had the heart sounds, what were the particular heart sound that we said what this one was? The pericardial knock. The pericardial knock was after which type of process? So S1 is you're in the ventricular type of systole process, and then after that you have S2, which you're going into the ventricular diastole process. In the early phase of diastole, from early up to mid diastole, we have a very interesting type of heart sound that's due to the rapid ventricular filling process. That is called the pericardial knock. So you'll have a pericardial knock in the early phase, early to about mid phase of ventricular diastole. The next thing is if we were to take a look at the EKG changes in constrictive pericarditis, you have this ability to reduce the electrical activity, because if you have a lot of this fibrous and elastic tissue that's presenting in the pericardial cavity, that's altering or impeding the electrical flow from the actual ventricles to the electrodes on the heart. And so one of the things that you may see is you may see these lower QRS voltages, which could be indicative of a patient who has constrictive pericarditis. But this is on the low end of utility. I would say definitely consider the knock in early to mid diastole. Consider potentially some QRS voltages that are lower. Here's what's really interesting. So sometimes we can do what's called a cardiac catheterization. We can put the catheter into the area like the right atrium, the right ventricle, and we can measure the pressures there. When we measure the pressures, we can actually measure the right atrial pressure, which is kind of like looking at what's called the jugular venous pressure waveform, since they're pretty much similar. When you look at this jugular venous pressure waveform, there's different waves, but the real important wave that we really need to know for these patients is the Y wave. In patients who have constrictive pericarditis, the Y wave is kind of indicative of early diastolic filling, okay? So what happens is, in these patients who have constrictive pericarditis, in the early to mid phase of diastole, what did I say happens? A massive amount of blood flow moves from the right atrium down into the right ventricle, a massive amount. And so what will happen is we can correlate that knock with the rapid flow of blood during early to mid diastole with the rapid flow of blood coming down from the jugular vein, down into the right atrium, and then down into the right ventricle. And so what happens is, at the same time you have this pericardial knock during ventricular diastole, you have this rapid drop and pressure of the jugular venous waveform, which is called a deep Y descent. And this is due to a rapid flow of blood that's moving into the right ventricle, across the from the right atrium into the right ventricle during early to mid diastole. Okay, so that'd be on your JVP tracing. The other thing from the cardiac catheterization is we can look at the ventricular pressure. So again, from the cardiac cath, we can actually use a JVP tracing, and from the cardiac cath, we can do ventricular curve tracing, pressure curves. So we can look at the left ventricle and the right ventricular pressure curves. What we see is if we match this up with the right atrial pressure curving or the JVP tracing, you can see that you're going to have here your ventricular systole, and then we're going to get ready at this point, same point for that JVP tracing, to go into ventricular diastole. When the blood moves from the right atrium into the right ventricle during early diastole, what did I say was evident here? That gives that knock sound, a rapid flow of blood. When the rapid flow of blood goes from the right atrium to the right ventricle, that drops the jugular venous pressure. You get that deep Y descent. It also drops the ventricular pressure pretty intensely, and you cause this rapid descent of the ventricular pressure curve. Once blood enters into the ventricle, the blood won't, remember, what did I say happens with the rigid pericardium? Blood will enter into the ventricle, but what happens is the ventricles won't be able to expand anymore because the pericardium is preventing them from expanding. So they get filled up with blood quickly, they stop. They can't expand anymore, so what happens to the pressure within that cavity then? It starts rising, 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 and eventually it plateaus. And so what happens is you see this huge drop, which correlates with their deep Y descent and their pericardial knock. And then because they can't expand the ventricle anymore, the pressure rises, rises, and plateaus. If you look at this type of configuration of that ventricular pressure curve during ventricular diastole, it looks like a square root. And so we call this the square root sign. And this is something that we can see from the cardiac cath procedure of the ventricular pressure curve, correlating with the JVP tracing, the right atrial pressure curve, and correlating with the pericardial knock during early to mid diastole. The other thing that's really important is because the pericardium is wrapping around the ventricles and is restricting the expansion of the ventricles in both left ventricle and right ventricle, there's a sense of what's called ventricular dependence between those two. And so their pressures are kind of correlating, they depend upon one another. So remember I told you that there's a lot of shifting of the septum back and forth. So that causes these actual ventricles to be kind of coupled with one another. And so their end diastolic pressures tend to be very equal due to the constricted pericardium all the way around the left ventricle and the right ventricle. And so that's a big thing because in patients who have something called restrictive cardiomyopathy, these pressures are actually different and they're not coupled properly. Usually the left ventricular end diastolic pressure is greater than the right ventricular end diastolic pressure in restrictive cardiomyopathy. Okay, so these are key things that I want you guys to remember. Out of all of these, what are the big things? Pericardial knock during early diastole, deep Y descent on the JVP tracing during early diastole, and a deep drop in the pressure in the ventricles, and then a quick rise and plateau, which is the square root sign of the ventricular pressure curve on the cardiac cath. Okay, what are some other tests that we can do for these patients? You can do an echo. Remember, in an echo, what did I tell you happens? Because that pericardium, again, is really restrictive and not allowing for the ventricle to expand during diastole properly, blood will come from the vena cava down into the right ventricle. It'll actually start to expand quickly. When it expands quickly, it stops because the pericardium resists it from expanding. If it can't expand out into the pericardium, it has to expand some other direction. And so it pushes the septum towards the left side. And so you see this thing called a septal bounce during the inspiratory process because it's more pronounced. During inspiration, you suck more blood into the right side of the heart. And so it'll cause more blood to rush in. It won't be able to move against the pericardium because it's rigid. Instead, it'll move against the septum and shift it towards the left ventricle. And so that's what you may see as a septal bounce. One of the best tests, though, for looking at constrictive pericarditis, because you can see calcifications, you can see any types of thickening of the pericardium, is you can do a CT or MRI of the heart. And this may be a very, very good test, one of the best tests to see any types of calcifications or thickened pericardium and constrictive pericarditis. All right, so that's constrictive pericarditis. Let's now talk about the diagnosis of cardiac tamponade. And we've already kind of talked about the effusions via utilizing echo. Let's talk about tamponade now. All right, so the diagnosis of cardiac tamponade. So what are we really depending upon on these patients? We obviously know their clinical features, right? The obstructive shock, we already know the pulsus paradoxus, we know the Beck's triad. In these patients, if we have a very high concern for a patient who has cardiac tamponade, the best thing to do is really an echo. We'll talk about that in just a second, but you also can get an EKG. If you're looking at the EKG on telemetry and you're saying, oh, this looks a little odd, and you see the voltages of the QRS complexes are really, really tiny, what could that be due from? Well, generally it's any kind of air, any kind of fluid, or obese patients that are having a lot of electrical impedance. The electrical activity going from the heart to the chest wall is impeded by something. In constrictive pericarditis, it was due to the fibrous tissue. In cardiac tamponade, it's due to all this dang fluid that's going to be between the heart and the chest wall. And so that can actually lower that QRS voltage in these patients. The other thing is if you look at an EKG, this would actually be a very late sign, but sometimes if there's this just like a fish inside like a cavity, like swimming around from side to side, sometimes the apex can alternate around a particular axis. So if we would look at, like, for example, lead 2, and the lead 2, the positive electrode would be here towards like the apex of the heart on the left hip area. What happens is all of that fluid that the heart is actually sitting in, the apex can move and twist around the baseline. And so imagine the apex at one point in time in that swinging process, it's pointing this way. That positive electrode, the QRS vector, the mean QRS vector, is pointing towards that positive electrode. That'll give me this type of QRS complex, a very large amplitude one. But then it's swimming this way and it swims this way. When it swings this way, now the apex is pointing over here and the positive electrode is like right here. This mean QRS vector is not going to be moving anywhere near that positive electrode. It's going to be moving kind of away from it or not as well towards it. And so because of that, the QRS voltage is going to drop because there's less of that vector moving straight towards the electrode. And so now you get this type of configuration. And it continues to alternate. So it'll swing back to the left, hit the electrode nicely, swing away from the electrode, lower QRS voltage, swing towards it, and you get the whole point. You're alternating the amplitude of the QRS complexes due to the heart swinging in that fluid. That process is called electrical alternance. Okay, so you can see lower QRS voltage, electrical alternance due to the heart swinging within the pericardial cavity. What's the best diagnostic test though? It's an echo. That's what you really need. When you look at the echo, whenever a patient has all of this fluid, it's compressing on the right atrium, compressing on the right ventricle, and compressing on the left atrium. These are the three most common areas that there's compression of. The left ventricle is a little bit thicker, so it's tougher to collapse that one. But it's usually right atrium first, right ventricle second, and usually left atrium last. Now, when did I say it's the most important to remember? It's collapsing it during the ventricular filling process. Remember, the heart is being compressed, it's being strangulated. You aren't able to get blood into the heart during the diastolic process. If the fluid is so large or so rapidly accumulating that it's compressing the heart during diastole and the right atrium and the right ventricle are collapsing, that's a positive sign. If the left atrium is collapsing, that's a positive sign. Here's the other thing. If you're collapsing, imagine you're squeezing down on the right side of the heart. Can you get blood to move into the right atrium from the inferior superior vena cava? No. And so what will happen to that superior vena cava or JVD? It'll plump up. What will happen to the IVC? It'll plump up. And so you can get things called plethoric IVCs. So you have collapse of the right atrium, right ventricle, plethoric IVC, and something called respirophasic changes, which is blood flow across the mitral valve and tricuspid valve during inspiration. In these patients, most of the blood flow across that tricuspid valve is increased every time you take a breath in. Remember what happens when you take a breath in? Drop my intrathoracic pressure, suck blood into the right side of the heart. And it's going to flow quickly across the tricuspid valve during an early phase of diastole. And then again, the ventricles are going to try to stretch, but they get hit by the pericardium and they can't stretch anymore. So they have a massive flow of blood across the tricuspid valve during inspiration. And that is another positive finding of cardiac tamponade. So again, we need the EKG, but really what we need is the echo. Now that we've diagnosed all of these conditions, let's treat them, baby. All right, so let's talk about the treatment of acute pericarditis first. So we know it's inflammation. That's the issue. The inflammation is causing the chest pain. It's causing the friction rub, a lot of those EKG changes, and maybe even a new or worsening effusion. How do we reduce the inflammation? Well, there's a couple different drugs that we can give. The first one is NSAIDs. High-dose NSAIDs are going to be the first preferable therapy. So ibuprofen, naproxen, indomethacin. There's been shown some research that aspirin may be superior in these patients, so you can consider aspirin as well. Now, when you're giving these high-dose NSAIDs, you should also give something that protects the gastrointestinal lining from all the high hydrochloric and erosive effects of that high hydrochloric acid production in these patients. So we can give something like a PPI or an H2RA to reduce a lot of the gastroerosion from these high-dose NSAIDs. But again, that's what you're going to be giving is NSAIDs because that reduces a lot of the inflammatory cytokines, particularly prostaglandins, by inhibiting the cyclooxygenase enzyme, right? Now, another drug that you can give to reduce inflammation is corticosteroids, things like prednisone, methylprednisolone, things of that nature. However, there has been studies that have shown that there is a high risk of recurrence with utilizing steroids. So we shouldn't really go to these as a first-line agent. They should be more of a second line in situations where there's a contraindication to giving NSAIDs. What would that be? NSAIDs can really jack up your kidneys, especially if you have end-stage renal disease or uremia. You might not want to give NSAIDs. Or if they have nasty peptic ulcer diseases, NSAIDs can also increase the risk of worsening that. So in those situations of uremia or peptic ulcer disease, might not be a good idea to give NSAIDs. Instead, you can give something called corticosteroids. Now, that's one reason. Now, the other reason that you would potentially give these to patients is not only if they have uremia, right, because that's going to be good for those patients who, again, are likely end-stage renal diseasers, but they have an inflammatory condition, like an autoimmune condition where there's lots of inflammation from those autoantibodies. What do you use to treat the flare-ups of autoimmune attacks? Steroids. And so steroids may be beneficial for those patients who have some type of autoimmune disease, but eventually you're going to want to convert them over into an immunosuppressant for more long-term treatment. So NSAIDs, high dose, first line, contraindication to that, steroids. Or if they have uremia and autoimmune diseases, you can consider steroids, but convert them over to immunosuppressants. Now, here's the big thing. Because we really want to reduce the risk of recurrence, recurrent attacks of acute pericarditis lead to constrictive pericarditis. There's been research that shows that colchicine may be effective in reducing the recurrence of these events. And so that's why we give this drug called colchicine. It inhibits the microtubules with the neutrophils, which is important in the inflammatory process. So we'll give colchicine as an add-on to NSAIDs to reduce the risk of recurrence, okay? And the contraindication to colchicine will be the same contraindication to NSAIDs, so end-stage renal disease or peptic ulcer disease. Then, because pericarditis is due to an underlying trigger, a cause, usually viral, it's usually just supportive care, it'll go away in time. But if it's something like uremia, you're probably going to need dialysis for those patients. If it's some type of neoplasia, they're probably going to require some type of chemo, radiation therapy, maybe surgery. And if it's autoimmune, again, we can do steroids in the interim, but switch them over to the more long-term care with immunosuppressant therapy. The last thing that you should understand with the patients who have pericarditis is when to hospitalize them, because some patients you can send them home with high-dose NSAIDs and colchicine and they'll be fine. But the patients who have very high fevers, who have very high white counts, and when you put an echo on their chest and you find a very large effusion, a new effusion, or an enlarging effusion, those will be patients I would not want to send home because they have a high risk of progressing, getting sicker. Maybe they have a purulent type of effusion, or they're at high risk for a bacterial infection that can cause a purulent effusion, or they're at high risk of tamponade. So I would not send those patients home, and that would be an indication for me to want to admit them for observation overnight. So do not forget that. All right, the next one is constrictive pericarditis. How do we treat this one? So with constrictive pericarditis, again, what were the problematic issues with this? The left-sided heart failure, right-sided heart failure symptoms, right? So in the heart failure symptoms, which one was more particularly common? The right heart failure, right? It was more common in that patient population. So we want to reduce the volume overload they have, to reduce the hepatomegaly, the ascites, the pedal edema, the jugular venous distension. How can we do that? We reduce preload. And so we fluid restrict them, we sodium restrict them. And if they're still volume overloaded after that, we give them diuretics. That's the big thing for this one. So the problem for these patients is the heart failure symptoms. The other one is that fibrotic pericardium. It's just never going to get better. What do? We got to get rid of that fibrotic pericardium. And so the best treatment for these patients, even though it has a higher mortality rate and high morbidity, is we have to remove the rigid and very fibrotic pericardium via a treatment called a pericardiectomy. And so that would be how we would treat constrictive pericarditis. Now, what about the pericardial effusion? For pericardial effusions, here's the big thing for this one. We have two particular types of treatments that we can do. We can drain it via a needle, ultrasound guided or CT guided needle removal of the fluid, what's called a pericardiocentesis. And what would be a reason that we would do that? A pericardiocentesis is more utilized in an acute situation, where particularly the pericardial effusion is causing a lot of pain. They have a high white count. They have a very significant fever. They have risk factors which would be at high risk for some type of purulent or pericardial, like nasty purulent infection of their pericardial fluid. Or they have high risk, or we know that they have some type of malignancy, and that malignancy is triggering their pericardial effusion. In those situations where they have a purulent effusion with high white count, high fevers, or they have a malignant pericardial effusion, and we want to acutely drain that to reduce some of the symptomatic issues that they're having with that, that would be the benefit of a pericardiocentesis. There's another beautiful thing with the pericardiocentesis. Not only is it good for acute drainages, and particularly those patients with purulent or malignant infusions, if we have a suspicion they have a high white count, a really bad fever, I can go and pull some of the fluid out of that pericardial cavity. Then I can send it for gram stains, I can send it for cultures, I can look for glucose, and I can look at protein. And if their gram stain comes back positive, their culture shows bacteria, their glucose is low, their protein is high, I may be concerned for that pericardial effusion that they have to be infected. And so that's something to consider. If I have some concern for malignant infusion that they have, because they have a lung cancer, they have a breast cancer, they have some type of lymphoma, and now they have a new effusion, I may want to go ahead and tap that and look for any kind of cytology to look for what kind of malignancy it could be coming from. These are indications for a pericardiocentesis. Now, if you've done the pericardiocentesis, you've pulled the fluid back, you send it for diagnosis, and you treat them, the other thing that you have to think about is what if they have a high risk of reaccumulating that pericardial effusion? So they have a purulent effusion and there's a risk of reaccumulating it, or they have a malignant pericardial effusion and there's a risk of them reaccumulating it. In those patients, sometimes we may have to open up the pericardium, put a hole in the pericardium and stick a drain into that pericardial cavity to continuously drain that pericardial effusion. And that goal for that is to, again, prevent reaccumulation. So these are the things that we can consider for pericardial effusion. Now, the last thing that we have to talk about is how do we treat the very devastating and scary cardiac tamponade. All right, so how do we treat cardiac tamponade? So in this patient, they are very hemodynamically unstable, right? So they can present with obstructive shock, right? So they're hypotensive, they're reflexively tachycardic, they have high vasomotor tone, all of those findings of high pulmonary capillary wedge pressure greater than or equal to 18, all of those findings. In those situations, these patients, they're going into shock. So sometimes it might be beneficial to try to support their mean arterial pressure, right? Their hemodynamics in that situation. So giving them a little bit of IV fluids to help to up their blood volume and increase their preload may be beneficial. And the other thing is giving them vasopressors to increase the inotropic action of the heart and to squeeze down the vessels a little bit more to support their blood pressure. So those may be situations to consider in a patient who is just in this occult shock or obstructive shock nature. Now that's only going to temporize them. What you want to also do to temporize them is to make sure that we keep that intrathoracic pressure low. Remember what I told you? Whenever your intrathoracic pressure is low, what do? You pull blood into the heart, increasing their venous return, increasing the preload, stroke volume, cardiac output. If you take away their intrathoracic pressure that's lower, in other words, you paralyze them to intubate them, or you're ventilating them with high positive airway pressure, that can cause their intrathoracic pressure increasing. And that can reduce the venous return to the heart. If you reduce the venous return, you reduce the stroke volume, reduce the cardiac output, and make them super hypotensive and increase the risk of going into cardiac arrest. So in these patients, it's important to keep their intrathoracic pressure lower because that's what's driving their increase in venous return. So support their hemodynamics with fluids, pressors, keep the PEEP if they're intubated low, and try to avoid intubating them so that you can keep their intrathoracic pressure on the lower end. But the end-all, be-all treatment for these patients with cardiac tamponade is we have to drain that fluid. So what do we do in an acute situation where their hemodynamics are tenuous and they're at risk of cardiac arrest? We drain the fluid. What's that called? A pericardiocentesis. We can do the pericardiocentesis, take off fluid, and then what also can we do with that acutely? Send it off to get tested to figure out what was the cause of it. Was it a purulent? Was it malignant? Was it what? What was the cause of this? Now, in certain patients where you've gone and you've drained off that fluid, sometimes in certain situations like hemopericardiums, aortic dissections, left ventricular wall rupture, some type of surgery, post-cabbage, whatever it was, where there's lots of blood within the pericardium, it's likely that it'll reaccumulate. And if it reaccumulates, they're going to go back into tamponade. So we want to put in a drain to reduce the risk of it reaccumulating and putting them back into tamponade. So what is that called? A pericardial window. So you can see how with pericardial effusions, it's kind of the same treatment. We have to drain that pericardium. That's the end-all, be-all treatment. Acutely, pericardiocentesis, send it off for labs. If it reaccumulates, high risk of reaccumulation, put in a drain. Ninjas, in this video, we talk about pericardial diseases. I hope it made sense, and I hope that you guys enjoyed it. As always, until next time.